Good morning, everyone. Today we will talk about rheumatoid arthritis and spondyloarthropathies. So let's start off with a case. We have here a 30-year-old female complaining of symmetric polyarthritis. 3 months prior to consult, she experienced having morning stiffness and hand pains associated with easy fatigability and body malaise. She consulted with her private physician and was given mefenamic acid and multivitamins, which afforded relief. 1 month prior to consult, there was recurrence of hand morning stiffness that lasted for more than an hour, again with fatigue and body malaise. This time around, she is also having pain and swelling of both hands. Intake of mefenamic acid lessens the pain and swelling, but hand morning stiffness persisted. 1 week prior to consult, hand morning stiffness, pain and swelling of hand joints are no longer relieved by intake of mefenamic acid. Furthermore, bilateral elbows and knees has also become swollen and painful. Thus, consult. At the clinic, physical exam revealed stable vital signs. Pertinent PE included presence of tender and swollen joints on the PIPs, MCPs, wrists of both hands, and swelling of elbows and knees. Lab workup were as follows. CBC showed mild anemia, elevated ESR and CRP, unremarkable urinalysis, rheumatoid factor and anti-CCP were elevated. With polyarthritis more than 6 weeks duration and elevated rheumatoid factor and anti-CCP, she was diagnosed to have rheumatoid arthritis. Rheumatoid arthritis is a chronic inflammatory disease of unknown etiology. It is characterized by symmetric polyarthritis that mainly affects small joints of hands and feet, although larger joints can be involved. It is a systemic disease that may also lead to a variety of extra-articular manifestations. Rheumatoid factor and anti-CCP are routinely included in the diagnostic evaluation of patients with suspected rheumatoid arthritis. It also serves as biomarkers of prognostic significance. The clinical features of rheumatoid arthritis are that it is more common in females than in males, with 2 to 3 is to 1 ratio. Incidence increases between 25 and 55 years of age, plateaus until the age of 75, and then decreases. Presenting symptoms result from inflammation of the joints, tendons, and bursae. Morning stiffness is a significant clinical feature, especially if the stiffness lasts for more than 1 hour and that eases with physical activity, as this is a characteristic of an inflammatory process. The arthritis, the earliest involved joints are the small joints. The initial pattern can be monoarticular, oligoarticular, or polyarticular. The distribution is usually symmetrical, and frequently involved joints are the MCPs, PIPs, and wrists. Flexor tendon tenosynovitis is a frequent hallmark. It leads to decreased range of motion, reduced grip and strength, and trigger finger. Patients also develop extra-articular manifestations. It develops in 40% of patients. And those that most likely to develop extra-articular manifestations are smokers, those with positive rheumatoid factor, or anti-CCP. Atlantoaxial involvement is a rare but clinically noteworthy because of its potential to cause compressive myelopathy and neurologic dysfunction. This is due to progressive instability of C1 and C2. When the disease activity of rheumatoid arthritis is poorly controlled, progressive destruction of joints and soft tissue due to chronic inflammation may lead to irreversible deformities. This slide shows you the classic deformities of rheumatoid arthritis. The first picture shows you Boutonniere's deformity of the third digit. In the second photo, try to look at the left thumb. This is an example of a Z deformity. Still focusing your attention on the same photo, still focusing on the left hand, the fifth digit is located, while the fifth digit of the right hand is subluxed. The most obvious deformity in the third picture is ulnar deviation, as one can see that the fingers are displaced towards the ulna. Notice also that the fingers are persistently flexed. This happens because of extensor tendon rupture. Rheumatoid nodules and muscle atrophy of the dorsum of the hands can also be seen. In the fourth picture, focus your attention to the fourth or ring finger. This is an example of a swan neck deformity, while the fifth digit is a boutonniere deformity. The picture on the extreme right is a knee showing rheumatoid nodules on the bony patellar surface. The description of each of these deformities has been tackled already during your second year, so I won't be describing each and every deformities, but I expect you to review the description which can be found in Harrison's. As mentioned earlier, 40% of RA patients may have extra-articular manifestations. These manifestations can be varied and can involve any organ system. Patients may have cervical myelopathy. Usually, RA patients with active disease present with anemia, and this is due to chronic disease, or they can have neutropenia, which may be part of Feltis syndrome. Feltis syndrome is defined by the clinical triad of neutropenia, splenomegaly, and nodular rheumatoid arthritis. Typically occurs in the late stage of severe RA and is more common in whites than other racial groups. RA patients may have higher risk to develop lymphoma compared to individuals without the disease. Vasculitis can develop anywhere, not just in the GI tract. Important to mention that RA itself is a risk factor for the development of osteoporosis. This is compounded by the fact that the drug that is commonly used to control the inflamed joints is notorious of causing osteoporosis. Even the eyes and oral cavity can be affected. The cardiopulmonary and renal system are not spared. There are genetic risk and non-genetic risk factors that are identified for the development of rheumatoid arthritis. The risk of developing the disease in the first degree relatives is 2 to 10 times greater compared to general population. Heritability estimates range from 40 to 50%. The genes that are identified include HLA-associated genes and non-HLA gene. HLA-associated genes include HLA-DRB1 gene, which encodes the MHC class II beta chain molecule. Another is the presence of shared epitope, QKRAA, is associated with anti-CCP antibody production and worse disease. For the non-HLA gene, PTPN22 gene encodes protein tyrosine phosphatase non-receptor 22 or PTPN22, which is a protein that regulates T and B cell function. DAP14 gene encodes an enzyme involved in the conversion of arginine to citrulline. Non-genetic risk factors include female sex. It is said that estrogen, which is more abundant in females, enhances immune response by stimulating production of TNF-alpha. Smoking and infection were also found to be risk factors. Exposure to various environmental factors increase the risk for RA, and cigarette smoke is one of the best characterized. Of interest, smoking also enhances the risk of developing anti-CCP positive RA in patients with the shared epitope. The mechanism of anti-CCP antibody generation from inhaled smoke probably relates to inflammation and activation of innate immunity in the airway, which then induces peptide citrullinarization. In a susceptible host, such as someone carrying the shared epitope and with genetically determined immune hyperactivity, these repeated insults, followed by chronic exposure to citrullinated peptides, would lead to the production of anti-CCP antibodies and other antibodies like rheumatoid factor. Listed in this table are the possible infectious causes of rheumatoid arthritis. And on the right side of the table are the potential pathogenic mechanisms. Let me walk you through the pathophysiologic mechanism of inflammation and joint destruction in RA. Genetic predisposition, along with environmental factors, may trigger the development of rheumatoid arthritis through an aberrant immune response. A major step in the mechanism is the activation of the CD4 positive T cell that results to T cell differentiation to either becoming Th1 or Th17. But for this to take place, two signals must be produced in order for the T cell to be activated. The first signal is made when the MHC class II molecule of the antigen-presenting cell, or APC, along with the processed antigen, binds with the T cell receptor. The second signal is made when the CD8086 of the APC binds with the CD28 of the T cell. After T cell activation, synovial CD4 T cells differentiate into Th1 and Th17 cells, each with their distinctive cytokine profile. CD4 Th cells in turn activate B cells, some of which are destined to differentiate into autoantibody producing plasma cells, immune complexes possibly comprised of rheumatoid factors and anti-CCP antibody may form inside the joint, activating the complement pathway and amplifying inflammation. T effector cells stimulate synovial macrophages and fibroblasts to secrete pro-inflammatory mediators, among which is tumor necrosis factor alpha or TNF alpha. TNF alpha upregulates adhesion molecules on endothelial cells, promoting leukocyte influx into the joint. It also stimulates the production of other inflammatory mediators such as IL-1, 6, and granulocyte macrophage colony stimulating factor. In RA, there is excessive production of these inflammatory cytokines. Aside from being a pro-inflammatory cytokine, TNF-alpha has also the role of promoting osteoporosis and joint erosion by tipping the balance of bone formation and bone resorption. TNF-alpha promotes pathways leading to osteoclast formation and inhibits pathways that promote osteoblast formation. For reasons that are unclear, the etiology of RA is still not understood. The synovial tissue, which is normally 1 to 2 layers thick in patients with normal joints, starts to grow. With biopsy of this tissue, one can see a variety of different cells that leads to a formation of a pannus, a thickened cellular membrane of granulation. At first, one can see T cells, B cells, or neutrophils, and a variety of other inflammatory mediators. With time, these inflammatory cells secrete a variety of different mediators, such as TNF, interleukin 1, and interleukin 6, that result in the degradation of the underlying cartilage and bone. How do we diagnose a patient with RA? To diagnose, We are guided by a classification criteria. The 1987 American College of Rheumatology or ACR classification for RA is an old but still useful criteria in the clinical practice. The reason why we are still teaching you this. This criteria comprises 7 parameters. A patient is said to have RA if he or she has satisfied 4 out of 7 criteria. Criteria 1 through 4 must have been present for at least 6 weeks. So the parameters included in the criteria are morning stiffness, lasting at least 1 hour before maximal improvement, arthritis of at least 3 joints, arthritis of hand joints, symmetric arthritis, rheumatoid nodules, serum rheumatoid factor, and radiographic changes. The radiographic changes typical of rheumatoid arthritis on postero-anterior hand and wrist radiograph, which must include erosions or unequivocal bony decalcification localized in or most marked adjacent to the involved joints. The 2010 ACR EULAR criteria for rheumatoid arthritis is the one that you see in your Harrisons now. This criteria involves 4 domains: joint involvement, serology, duration, acute phase reactance. The criteria makes use of point system. In the joint involvement domain, the higher the number of small joints involved, the higher the points. For serology, the higher the titer of rheumatoid factor or anti-CCP or ACPA positivity, the higher the points, while the duration of more than 6 weeks is given a point, while no point if less than 6 weeks. For the acute phase reactance, abnormal CRP or ESR is given the maximum point of 1. In order to make a diagnosis, at least 6 points is reached. This newer criteria was developed in order to early catch those having inflammatory arthritis. The earlier the patient is diagnosed, the earlier the treatment given, the chances of preventing joint destruction and disability is more likely. The following are the common laboratory tests that we request in patients with RA. Rheumatoid factor is an autoantibody that binds to the Fc region of human IgG. IgM is the most common RF isotype, but IgG and IgA rheumatoid factor may also be detected in the serum. Like rheumatoid factor, the higher the level of anti-CCP antibody, the higher the correlation with erosive joint disease, functional disability, and extra-articular disease. Between the two, more specific test for RA is the anti-CCP. Although these two serologic markers are part of the domain assessed in the 2010 criteria, be aware that a small portion of RA patients will remain seronegative throughout the course of their disease. ANA can be present in 20% to 30% of patients with RA. ANA is more common in RA patients with higher titer rheumatoid factor and extra-articular manifestations of the disease. In contrast to systemic lupus erythematosus, in which complement levels are low, complement levels in RA are usually normal or increased because complement is an acute phase reactant. During active disease activity, ESR and CRP are elevated. The CBC may show anemia and sometimes leukopenia. ALT and AST are being requested usually to monitor side effects of the most common DMARD used to manage RA, methotrexate. Several imaging modalities can be used to detect characteristic bone and joint changes of RA. Plain radiography can detect periarticular osteopenia, the initial radiography finding. It can also detect soft tissue swelling, symmetric joint space loss, subchondral erosions, and joint subluxations, especially if there is the presence of severe destruction. Ultrasound can detect more erosions than plain radiography, and this detects synovitis. Another advantage is that it's portable and there is no radiation exposure. However, it's technician dependent. The MRI, on the other hand, is the most sensitive for detecting synovitis, joint effusions, early bone and bone marrow changes. However, due to the expense, it is not practical to use. Approach to treatment in rheumatoid arthritis. The goal is early aggressive therapy to prevent joint damage and disability, frequent modification of therapy where utilization of combination therapy where appropriate, individualization of therapy in an attempt to maximize response and minimize side effects, and achieving remission of clinical disease activity. The current treatment options for RA are multifocal. First, non-steroidal anti-inflammatory drugs are commonly used. In addition, we often use corticosteroids such as low-dose prednisone, which are often used as bridge therapy or to allow treatment for acute flares. In addition, there are a variety of other more potent so-called disease-modifying drugs, including methotrexate, hydroxychloroquine, sulfasalazine, leflunomide, and others. In the past 5 to 6 years, there have been biologic modifiers or biologic disease modifying drugs approved. Moreover, in the past few years, clinicians have learned that the combination of biologic disease modifying drugs with some of the synthetic disease modifying drugs has added benefit and may provide more complete response than either synthetic disease modifying anti-rheumatic drugs or biologic DMARDs when used as monotherapy. The newest drug is the small molecule Janus kinase inhibitor, tofacitinib. Now let's talk about biologic DMARDs in more detail. Biologic DMARDs are structurally engineered versions of natural molecules. They are designed to specifically target pathogenic mediators of joint inflammation and damage. It has been shown in clinical trials to significantly inhibit the progression of joint damage. This figure illustrates the cytokine-based strategies being investigated for the treatment of inflammatory diseases. The upper left panel shows the normal interaction between an inflammatory cytokine and its receptor. When the cytokine binds to its receptor, inflammatory effector molecules are produced. Example of which inflammatory cytokines include TNF-alpha, interleukin-1, and interleukin-6. The upper right panel shows how a cytokine can be neutralized, either by a soluble receptor or by a monoclonal antibody, so that it cannot bind to its cell surface receptor. Example of this mode of inhibition are the soluble TNF receptor fusion protein and the interleukin-1 receptor and the monoclonal antibodies against TNF-alpha like infliximab, adalimumab, and interleukin-6. In rheumatoid arthritis, the levels of TNF become elevated in the synovium, overwhelming the soluble TNF receptors that normally regulate pro-inflammatory activity. TNF molecules are thus able to bind to receptors on the surface of synovial cells, triggering multiple destructive events. TNF induces the production of other pro-inflammatory cytokines, including IL-1, IL-6, and IL-8. Thus, targeting TNF may inhibit the destruction activity of both TNF and other cytokines. Going back to the pathomechanism, blocking TNF through anti-TNF biologics will block several pro-inflammatory mechanisms in the joint, such as the upregulation of adhesion molecules on endothelial cells, thus influx of leukocyte into the joint is prevented. Since TNF stimulates the production of other inflammatory mediators, the IL-1, IL-6, and GM-CSF, blocking TNF will also block the formation of these mediators. Furthermore, osteoporosis and joint erosions can also be partly prevented. This slide shows you the comparison of the different anti-TNF. They differ in their structure, administration, and the capability to develop neutralizing antibodies. Etanercept is a human fusion protein receptor, while infliximab is a chimeric monoclonal antibody, meaning the monoclonal antibody structure is made up of both coming from mouse and human, while adalimumab and golimumab are fully human monoclonal antibodies. Anakinra is a recombinant form of the naturally occurring interleukin-1 receptor antagonist, while abatacept is a soluble fusion protein CTLA-4. It inhibits the co-stimulation of T cells by blocking CD28, CD8086 interactions, thus inhibit the function of antigen-presenting cells by reversing signaling through CD80 and CD86. Going back to the pathophysiologic mechanism of RA, abatacept acts on this step. It prevents the completion of the signals, specifically prevention of signal 2. Thus, T cell activation will not take place. Rituximab is a chimeric monoclonal antibody directed against CD20, a cell surface molecule expressed by most mature B lymphocytes. Binding of rituximab to the CD20 of mature B cell will result to direct apoptosis of the B cell, or it renders it to be the target of membrane attack complex, or be attacked by the antibody-dependent cellular cytotoxicity mechanism. All of these mechanisms lead to death of the mature B cells. This is the part of the mechanism where rituximab acts on. Tocilizumab is a humanized anti-interleukin-6 receptor monoclonal antibody. It binds to both the membrane interleukin-6 receptor and soluble interleukin-6 receptor to inhibit interleukin-6 signaling in RA. Thus, signal transduction is inhibited. Lastly, we talk about tofacitinib, the newest kid in the block, a JAK inhibitor. Tofacitinib is not a monoclonal antibody but a small molecule that acts inside the cell, specifically inhibiting cell signal transduction, preventing gene transcription and cytokine production. It is a JAK inhibitor. JAK stands for Janus kinase. A kinase is generally an enzyme that catalyzes the process of phosphorylation, an important step to link cytokine signaling from membrane receptors to signal transducers and activators of transcription, or STATs. Cytokine binding to its cell surface receptor leads to receptor polymerization. Tofacitinib inhibits the phosphorylation and activation of JAKs. JAKs cannot phosphorylate the cytokine receptors. Therefore, the receptors cannot dock STATs. Since the STATs cannot dock, they are not phosphorylated or activated. Gene transcription and cytokine production are thereby inhibited. In summary, rheumatoid arthritis is a systemic autoimmune disease predominantly affects the joints, but may also present with extra-articular manifestations. It is a disease more common in females under reproductive age group. Genetic and non-genetic risk factors were identified. 1987 and the 2010 classification criteria were discussed. The newer criteria aim to diagnose early inflammatory arthritis so that early treatment can be instituted, preventing permanent damage and disability. Among the serologic tests, anti-CCP is more specific to RA than rheumatoid factor. Different treatment options were discussed. The actions of the targeted biologic DMARDs were pointed out in relation to the pathomechanism of the disease. Now we discuss spondyloarthropathy. Spondyloarthropathy are a group of overlapping disorders that share certain clinical features and genetic associations. These include ankylosing spondylitis, reactive arthritis, psoriatic arthritis, enteropathic arthritis, juvenile onset spondyloarthritis, and undifferentiated spondyloarthropathy. We have here a 23-year-old male complaining of chronic back pain. 9 months prior to consult, this patient experienced bilateral Achilles tendon pain. 7 months prior to consult, bilateral Achilles tendon pain persisted. But this time, he was having dull pain of the buttocks associated with low back morning stiffness of more than 1 hour, relieved by movement or exercise. 4 weeks prior to consult, there was an increase in severity of back pain with difficulty getting up, especially in the morning. Bilateral Achilles tendon pain and swelling persisted. He denies having antecedent infection prior to the symptoms. Pertinent physical examination include a positive Schober's test since the patient's result was 0.5 cm. Furthermore, the insertion of the Achilles tendon to the area of the calcaneus was tender and also swollen. With the age of the patient, that is relatively young, complaining of chronic low back pain, which was relieved by exercise and movement, the impression of ankylosing spondylitis was considered. Ankylosing spondylitis is a chronic inflammatory disorder that primarily affects the axial skeleton and leads to limitation of spinal mobility and adjacent structures. Involvement of peripheral joints and extra-articular structures are also possible. It affects young adults, primarily males with peak age of onset between 20 and 30 years of age. The etiology is pointed on a combination of genetics and environmental factors. And the gene that is associated with ankylosing spondylitis is HLA-B27, which is a strong genetic risk factor and present in 95% of the patient. AS is categorized by enthesopathy, which means an inflammatory attack where tendons and ligaments attach to bones or joint capsules. This is called enthesis. In the spine, The primary site for this enthesis is where the long spinal ligament or the anterior longitudinal ligament attaches to the front of the vertebrae. Inflammation of the enthesis is called enthesitis. Disease typically originates in the sacroiliac joints, where MRI reveals inflammation in the postero-inferior capsular region and subchondral bone of the synovial portion of the joint. Detailed histopathologic studies in early disease are limited owing to the inaccessibility of biopsy material. A controlled study of sacroiliac biopsies from AS patients at various stages of disease and control showed cellular infiltration with lymphocytes, macrophages, and plasma cells in the synovium and subchondral marrow as the earliest features of disease. Later, features include the development of pannus extending from both synovium and subchondral bone marrow, with erosion of articular cartilage and its replacement by granulation tissue. Osteoclast formation and erosion of subchondral bone account for the typical widening of the joint space seen on plain radiography. Enthesitis is also evident in later stages of disease at the insertion of the posterior capsule. Reparative changes include cartilage metaplasia at sites of active inflammation, followed by its calcification and then replacement by endochondral bone, leading to the obliteration of the joint space by ankylosis. Paraarticular changes include both bone sclerosis and fat replacement of bone marrow. Immunohistological studies show the presence of dense cellular infiltrates of T lymphocytes and macrophages expressing TNF-alpha. Transforming growth factor is evident at sites of new bone formation. This diagram shows you the different stages of ankylosing spondylitis, comparing it from a normal spine. Okay. So the first picture shows you the normal spine, while in early ankylosing spondylitis, you can see inflammation in the enthesis, okay, the attachment of the anterior spinal ligament to the vertebral body. And later on, during the advanced ankylosing spondylitis, there is already the ossification of this area here in the enthesis, causing fusion of the vertebral bodies. The clinical feature of ankylosing spondylitis is inflammatory back pain. This is the hallmark of ankylosing spondylitis. It is characterized as dull pain, insidious in onset, felt deep in the lower lumbar or gluteal region. Sacroiliitis is the earliest manifestation of ankylosing spondylitis. And this is associated with a radiographic sacroiliitis and often spondylitis. In order to characterize a back pain as inflammatory in origin, 4 out of 5 of the parameters of the ASAS criteria must be met. Age at onset less than 40 years old, insidious onset, improvement with exercise, no improvement with rest, and pain at night with improvement upon getting up. Other features include kyphosis resulting to a stoop posture, low back morning stiffness up to a few hours duration that improves with activity and returns following inactivity. Arthritis, enthesitis, or osteitis is also common. The picture on the right side of the slide is an example of enthesitis of the Achilles tendon on the left. Extra-articular feature is possible, and the most common of which is acute anterior uveitis, occurring in 25 to 40% of the patient. On physical examination, there's marked limitation with the following maneuvers: Schober's test, lateral spinal flexion, occiput tragus to wall, cervical rotation, chest expansion, and intermalleolar distance. This is how we do the Schober's test. The lateral spinal flexion, the occiput to wall, chest expansion, and intermalleolar distance. Other extraskeletal features, aside from acute anterior uveitis, include cardiovascular involvement, pulmonary involvement, neurologic involvement, renal, and gastrointestinal involvement. This is a picture showing you a patient with ankylosing spondylitis and his progression of deformities. ASA's criteria for classification of axial spondyloarthritis is to be applied for patients with back pain with 3 months or more duration and age of onset of less than 45 years. So for one to have or to be labeled having axial spondyloarthritis, there has to be an evidence of sacroiliitis on imaging, plus one or more SPA feature. And the SPA feature include IBP, arthritis, enthesitis, uveitis, dactylitis, psoriasis, Crohn's colitis, good response to NSAIDs, family history of SPA or spondyloarthropathy, and elevated CRP. Or you can use the HLA-B27 plus 2 or more SPA features. No laboratory test is diagnostic of ankylosing spondylitis. HLA-B27 is present in 80 to 90%. ESR, CRP are mildly elevated, anemia can be mild, and ANA, rheumatoid factor, and anti-CCP are negative. In imaging, these are the typical MRI lesions of the sacroiliac joint. To look for active inflammatory lesions, look for bone marrow edema, capsulitis, synovitis, or enthesitis. While for chronic inflammatory lesions, there is already evidence of sclerosis, erosions, fat deposition, and bony bridges or ankylosis. Sacroiliitis can be seen in X-ray. Predominantly, it is seen in the ilium. It shows as a poorly defined subchondral bone plate with blurring and irregularity of ligamentous portion of the sacroiliac space. The following are the terminology commonly applied to spinal abnormalities in ankylosing spondylitis. In an X-ray, vertebral body squaring are due to straightened or convex anterior margin of the vertebral body related to erosions. Syndesmophytes are ossification within the annulus fibrosus leading to the thin vertical radiodense area. Bamboo spine results from extensive syndesmophytosis, while dagger sign is a prominent fusion of the interspinous and supraspinous ligaments, producing a Saber sheath appearance. This is seen in the radiographic X-ray as single central radiodense line. Trolley track sign can also be seen because of fusion of the facet joints and ossification of the adjacent soft tissue. Treatment for ankylosing spondylitis includes non-pharmacologic and pharmacologic treatment. Do not forget to give the patient the non-pharmacologic treatment as this is a significant part of the management. Patient must be educated, provide regular home exercise. Physical therapy should include strengthening back muscles, improving posture, and increasing flexibility and range of motion. For the pharmacologic treatment, NSAIDs is the first line of treatment. It retards radiographic disease progression at 2 years. Sulfasalazine, given at 2 to 3 grams per day, is effective for the peripheral arthritis, but not on the axial involvement. Anti-TNF is given for persistent high disease activity despite conventional treatment. But take note, as the use of anti-TNF increases the risk for TB infection and reactivation. Secukinumab, or anti-IL-17A, is one of the newer biologics that can be given to ankylosing spondylitis. And there are studies that tofacitinib can also be given. So the next disease or condition under the spondyloarthropathy umbrella is a reactive arthritis. It is an acute non-purulent arthritis following an extra-articular infection. The term has been used primarily to refer to spondyloarthropathy following enteric or urogenital infections. The classic triad include arthritis, urethritis, and conjunctivitis, but it is present only in a small part of the spectrum. Bacteria had been identified as capable of triggering the clinical syndrome, and these include predominant organisms that causes urogenital and enteric infections such as chlamydia, salmonella, shigella, yersinia, and campylobacter species. S. flexneri has most often been implicated in cases of reactive arthritis. Reactive arthritis usually occurs in young adults with a history of an antecedent infection 1 to 4 weeks before onset of symptoms. Some do not manifest with clinical or laboratory evidence of an antecedent infection. Do not forget to ask the sexual habits or the sexual history, as some have been presumed to have venereally acquired reactive disease, especially for those with history of a recent new sexual partner. Reactive arthritis usually presents as asymmetrical and additive arthritis with involvement of new joints occurring over a few days. Joints of the lower extremities are most commonly involved. Dactylitis or sausage digit, characterized as diffuse swelling of a solitary finger or toe, is a distinctive feature of reactive arthritis. They may also present with tendinitis, fasciitis, and enthesitis, especially Achilles insertion, plantar fascia, and sites along the axial skeleton. Spinal and low back pain are quite common. Urethritis, conjunctivitis, uveitis, rashes, and nail changes can be extra-articular manifestations. The picture represents keratoderma blennorachica, which is a characteristic skin lesion associated with reactive arthritis. Lesions involving palms and soles consist of vesicles that become hyperkeratotic and ultimately forming a crust before disappearing. The diagnosis of reactive arthritis needs high index of suspicion in a patient with episodes of diarrhea or dysuria, acute inflammatory, asymmetric, additive arthritis, or tendinitis with extra-articular involvement. Reactive arthritis is a clinical diagnosis, so no definite diagnostic laboratory test is available. The treatment is high-dose NSAIDs and appropriate antibiotic treatment. DMARDs can be sulfasalazine or methotrexate, and a comprehensive management include counseling. Psoriatic arthritis. Psoriatic arthritis is an inflammatory arthritis that occurs in individuals with psoriasis. 60 to 70% of cases of psoriasis precedes joint disease. However, 15 to 20% of cases, arthritis precedes the onset of psoriasis, which can present a diagnostic challenge. The gene that is associated with psoriatic arthritis is the MHC class I gene, particularly the CW6. MHC class I molecules promote psoriatic arthritis by presenting arthritogenic peptides to CD8 T lymphocytes that is autoreactive in skin and joints. Trauma and infection also play a role. Wright and Moll described 5 clinical patterns of psoriatic arthritis, namely arthritis of the DIP joints, asymmetric oligoarthritis, symmetric polyarthritis similar to RA, axial involvement, spine and sacroiliac joints, and arthritis mutilans, a highly destructive form of disease. Nail changes is an important clinical feature. It can be in the form of pitting, horizontal ridging, onycholysis, yellowish discoloration of the nail margins, and dystrophic hyperkeratosis. Nail changes in the fingers or toes occur in 90% of patients with psoriatic arthritis, compared with 40% of psoriatic patients without arthritis. And pustular psoriasis is said to be associated with more severe arthritis. If a psoriatic patient presents with nail changes, it is actually a predictor that that patient may later on develop psoriatic arthritis. The following are deformities associated with psoriatic arthritis. The picture above is an example of a arthritis mutilans, while the picture below that is a picture of a toe with dactylitis. No laboratory test is diagnostic of psoriatic arthritis. ESR-CRP are elevated. HLA-B27 is found in 50 to 70% of patients with axial disease. Characteristics of peripheral psoriatic arthritis include DIP involvement, including the classic pencil in cup deformity, marginal erosions with adjacent bony proliferation or whiskering, small joint ankylosis, osteolysis of phalangeal and metacarpal bone with telescoping of digits, and periostitis and proliferative new bone at sites of enthesitis. The Caspar criteria is used to diagnose a patient with psoriatic arthritis. To meet the Caspar criteria, a patient must have inflammatory articular disease. It can involve the joint, the spine, or entheses with at least 3 points from any of the following 5 categories: evidence of current psoriasis, a personal history of psoriasis, or a family history of psoriasis. Typical psoriatic nail dystrophy observed on current physical examination, A negative test result for rheumatoid factor, either current dactylitis or a history of dactylitis recorded by a rheumatologist, and a radiographic evidence of juxta-articular new bone formation in the hand or foot. Treatment of psoriatic arthritis include methotrexate, sulfasalazine, cyclosporine, and these are effective for peripheral arthritis. However, if there is axial involvement, such as the sacroiliac joints or the spine, it is better to use biologics such as anti-TNF, secukinumab, ustekinumab. Apremilast are oral antiphosphodiesterase 4 inhibitor that is also found to be effective in treating psoriatic arthritis. Recent studies show that tofacitinib are also effective for those with inadequate response to another DMARD. The fourth disease under spondyloarthropathy is enteropathic spondyloarthritis. This is an inflammatory arthritis that accompanies Crohn's disease and ulcerative colitis. The prevalence of ulcerative colitis and Crohn's disease both have 0.5 to 0.1%. Enteropathic arthritis can occur in peripheral, axial, or mixed pattern. The prevalence of IBD in ankylosing spondylitis is 5 to 10%. HLA-B27 is found in up to 70% of patients with IBD and AS. Mutations in NOD2 CARD15 gene on chromosome 16 were identified to be associated with enteropathic spondyloarthritis. It has been said that the GI tract inflammation increased permeability resulting in absorption of antigenic material. The autoimmune response was induced by molecular mimicry, and it has been shown to be associated strongly to HLA-B27. Aside from arthritis, extraintestinal manifestations of IBD include uveitis, pyoderma gangrenosum, erythema nodosum, enthesitis, and finger clubbing. The picture shown here is an example of a pyoderma gangrenosum. The peripheral arthritis is characterized as polyarticular and asymmetric, non-deforming and non-erosive, acute self-limited attacks of oligoarthritis that often coincide with relapses of IBD. In ulcerative colitis, peripheral arthritis correlates with degree of active bowel inflammation. For axial arthritis, it involves sacroiliitis and spondylitis. Insidious onset of low back pain, morning stiffness has been described, exacerbated by prolonged sitting or standing. The axial arthritis is more common in Crohn's disease than the ulcerative colitis. 30 to 70% carry the HLA-B27 gene in AS with IBD. ESR-CRP are elevated. Radiographic changes in axial skeleton is the same as in uncomplicated AS. Diagnosis is based on careful history and clinical examination, supplemented by imaging. Anti-TNF infliximab results in remission of GI manifestations. NSAIDs are first-line treatment for joint inflammation in both axial and peripheral disease, but can also precipitate flares of IBD. Sulfasalazine treatment for colonic inflammation is effective in peripheral but not axial arthritis. Lastly, undifferentiated spondyloarthritis. These patients may present with some features of one or more of the spondyloarthritis, but does not really meet a specific criteria. Example, a patient may have feature of reactive arthritis but the triggering infection remains clinically silent. The management is similar to that of other spondyloarthritis. In summary, there are 6 spondyloarthritis under the spondyloarthropathy umbrella, and we have discussed 5 of the 6, namely ankylosing spondylitis, reactive arthritis, psoriatic arthritis, enteropathic spondyloarthritis, and undifferentiated spondyloarthritis. All of them are associated with HLA-B27 with common clinical features that include axial involvement, peripheral arthritis with additive asymmetric pattern, and involvement of the entheses. NSAIDs DMARD, anti-TNF, anti-interleukin 17, and anti-1223 are the treatment used to control the disease activity of spondyloarthropathy. Thank you for listening.